Sounds good.
Thanks. All right, we're off. Over to you, Mariano.
Well, actually, I'm going to pass it over to Nicole, which is going to give us a little bit of an introduction about this blog. So I don't know, Nicole, if you want to share your screen. You want me to stop sharing the screen?
Good morning. Yeah, if you'd like, I can very quickly share my screen and show everybody sort of what we've been working on. What I'll also do is in the chat now, I'm just going to post a link to the login page. So I'm just putting that in the chat box now for everybody to see. This link will also go on our website by the end of these rounds, so they'll be available from there. Essentially what we're working on, and it's still somewhat in beta mode, but we'd love to get some feedback about how it's going to actually work, is this forum, which I'll share now, which will give us the opportunity to post the cases prior to rounds each week, so there can be a bit of discussion. In addition to the cases, I think Mariano's planning on putting some tutorials and some sort of other interesting cases and just general educational material as well. So when you log in, it's a bit of a, almost like a Facebook platform. So when you first log in, it takes you to a feed, which will look something like, sorry, can everyone see my screen?
Yep.
Yep, cool. So it'll take you to a feed, which will just be sort of a list of topics and conversations that are going on. But probably the more useful page will be this topics page over here, which is where the actual cases will be in a sort of contained format. So what we'd love is for anyone who's interested to log in, have a look around, and then send us feedback. I guess the aim is to make this as interactive and useful for our community as possible. So we'd love to hear what you think and what we can do to make it more engaging or more educational or informative or whatever, however we can give you the best value for it. That's
awesome.
all I've got,
no, that's okay, and that's the idea. It should be extremely simple and easy to log in, and it's extremely easy to navigate. So it's just to introduce that. I was wondering what would be the easiest way to invite everyone? Probably we should send an email with a link.
Yeah, so that link that I've just shared in the chat box is an invite, and then we can also send that via our Facebook page, our website, and email. So
Cool.
Yeah, so people can either request to join the group or we can send actual invitations, either way.
And I guess there we can also post the link to the Zoom meeting, so then everything related to this round is going to be somewhere there. So it's an easy place to very fast go and gather all the information that is necessary without, like I struggle a lot with the emails. If I need to start finding emails, it takes me 2 hours. Like I really love to have one place where I can go, just find everything I need for this and move on. Okay, so thank you very much. I suppose we now start with the first case, which is actually, I don't know if you receive an email or not. Probably, do you have the link to this case, which is the case number 8? If you don't, I can just post it on the chat. I'll do that anyway, just in case. Okay, let me see if I can find the chat. The chat sometimes is a bit naughty, that it goes away, and I don't know. Okay, let's find it. Found it here. Okay, so this is the link to the case that we're gonna be talking about now. So open it, take a look. The history is, I remember this case, I worked with this case, and I struggled with this case, and I learned a lot from this case. That's why I like to share it. I think the reason for this case was the cat was going to go for a dental or something like this. So they were just taking radiographs to kind of a regular healthy check, if you want. And then they didn't like what they saw on the radiographs, and then they referred to the uni. And this is, I said, well, can I look at the images? And then this is what we got. So yes, take a look. And then we, as usual, we first go a bit crazy in terms of trying to bring all the findings even if we don't know how to explain them, even if they are contradictory, don't care. We just bring everything we think, and then we discuss about the findings. We decide what is worth keeping, what is worth trashing, and then we move on in trying to explain what is happening. Okay, so first part, take a minute to look at the case. There are multiple images. I just put these two. I think these two are the best in terms of quality and what they represent. Take a look, and then we start bringing everything we feel is abnormal. Whenever someone is ready to bring the first abnormality, I'm all ears.
I'll start.
Okay, cool.
There's increased density in the right hemithorax.
I agree.
Which is causing a left mediastinal shift, I think, as long as the radiograph's sort of nicely lined up.
Okay. Sorry about that. Okay, so increased opacity of the right hemithorax. I love that. So right hemithorax. And then mediastinal shift.
Maybe not. I mean, I guess I was sort of thinking, if it was atelectasis, then the mediastinum would have shifted towards that right side, whereas in this case, if anything, the mediastinum looks centered or towards the left.
Okay, good. And again, this exercise is hard because I think the brain automatically tries to explain things, and things that we cannot explain, we don't even mention. Make sense? This is how we usually operate. Mm-hmm. And I invite you to try to stop that, which is extremely hard, but don't try to explain, just call what you think is abnormal. And then it's like assertion, the oncology surgeons that they just, one goes in and takes everything out without caring about how you're gonna close that, makes sense? And then you need someone else closing. So for now, don't try to explain, just bring things like what you're saying about the mediastinal shift is very important. So even if you cannot explain it, even if you are uncertain, it's good to bring it. Makes sense? It's good to say, well, I'm uncertain about that. That's perfect. And then we see if it fits, if we can use that information, or we just decide. Sometimes we just ignore information. Sometimes we see something there, it doesn't fit, but at the end of the day, we need to say, well, I don't know. But that's also valuable. So just bring everything that you think it looks abnormal, even if you don't know how to explain it.
Marianne, I've got something that's kind of a description, but also a bit of a question. Something that's sort of annoying me about this case, in that I feel like on the cranial border, so I'll sort of draw it, there's border effacement of the pericardial, the cardiac silhouette rather, on the cranial border, but I can see a clear sort of definition on the caudal border. So if I draw the caudal border there, I can see. But on the cranial border, I feel like there's no real clear. I'm happy for someone to disagree. I feel like I can sort of create a border with my mind, but I don't actually feel like it's there, if that makes sense.
Now you're talking about the cranial border. So
the cranial border.
Okay, good. Okay, yeah. That's enough. That's enough. So and you feel that that's abnormal, normal. You just want to mention that you can see the border. That's perfectly fine. So you can see
So I can see the caudal border, but I can't see the cranial border, and I find that a bit unusual. I've never seen a case like that.
That's perfect. Perfect.
Yeah.
Okay. Anything else?
It's an adult dog. Its epiphyses are fused. Its abdominal detail is heading towards the ground glass appearance. So I suspect that it's either not fat, whereas body condition looks reasonable from other areas of the body. So I sort of suspect it could be abdominal fluid. Then there's cranial to the heart. And at the carina there seems to be what's probably edema. Not nodules. I don't want to get a reputation as the nodule man.
That's good. I mean, we again, we bring everything we think, and without being shy. No concerns about being wrong now. Then we filter. That makes sense. Then we filter everything we said, and we say, well, I think I changed my mind, and that's perfectly fine. I think it's very bad not to say things or to put abnormalities in question. Makes sense, and just say, I don't know, I just ignore it. In my eyes, most of the mistakes that we make are like that, are things that we cannot explain, and because we cannot explain them, we ignore them. Makes sense? So it's better to just be the surgeon that is taking things out, just bring everything you think, and if that is the case, and I disagree, I'm gonna say I disagree because of this reason. Makes sense? So, but at least we talk about that feature, and we just not ignore it, which is probably the worst you can do. So, okay, I take note of your findings. Anyone else?
To me, the whole X-rays, well, both X-rays are quite underexposed.
Okay.
The diaphragm, I guess on both views, looks quite, well, particularly on the lateral, it looks quite flattened.
Okay.
And hold on, sorry, 5-year-old child butts in. The dorsal, I see the dorsal flexion of the diaphragm is quite far back. It's kind of almost looks at L1. And on the right cranial thorax.
I missed that last part. So in terms of the diaphragm, you're saying that it looks flat. And what was the other comment?
It looks like it's gone quite far back.
Okay.
Yeah, so sort of T13, L1. And I can also see soft tissue opacity on the right cranial, I think it's right because there's no markers, but right cranial chest consistent with a small pleural effusion.
Can you show me that?
Yeah.
Okay, good.
Yeah, there.
Good.
Yeah, that's what I've got.
Good. Anything else?
I was looking at potentially nodular area up here, but I can't see it on the DV or the VD.
Okay.
Also what I thought might be bronchi in this area, but I also can't see them on the orthogonal view.
Okay.
So I had to explain them. And just a huge amount of gas that it looks like it's in the stomach on this view, but on the orthogonal view, it looks like it's large intestine with a lot of ingesta in it, and reduced detail in the abdomen.
Okay. So, do you have anyone? So now we have a bunch of findings, and the idea was to put everything out. I'm tempted to kind of go one by one and give my opinion, but probably I should try to stay away from that and let you do that. Make sense? So in a very gentle way, because that's the idea. So any of you disagree with anything of what has been pointed out? Make sense? Do you want to say, someone mentioned this, but I'm not sure that is there because of this reason. Make sense? Do you want to be part of the critical evaluation of all of these abnormalities that we brought on? I'm happy to start, but it's also very cool if you can do that. Makes sense to say, well, I disagree with the nodules, and then you say why. Make sense? If you don't do it, I'll do it, but I'll give you the chance. What I will do is I'm gonna clear up the ones that I think probably should not distract us moving forward. And then I'm gonna start asking to try to go deeper in the features that I think are relevant. So to clear up, I think I'm gonna put together the description of the poor serosal detail with it's not a very thin cut, but it's not very, the body condition is not that much falciform fat. I'm gonna put that together with the exposure. So I think that the exposure and the technique and being a little bit thin, that explains the detail in the abdomen. Makes sense? So I will put all of those things together, and probably my conclusion will be that based on those contours, the serosal detail is not great, but it's a bit thin. So probably I will leave that as at least questionable. I'm not sure there is fluid there. I will leave that probably on the side. Then I will put them, what else I want to put aside. Probably the other thing is, both of you that were pointing out that nodules, they came back to the hilar region. Be very careful about the hilar region. We have big vessels there. Do you remember the grapes? Is where we have the most grapes superimposed. So you are so likely to confuse like a vessel, some summation with a nodule. If you think about nodules, go to the periphery. There's not so much lung there, and then see if you can replicate that. Make sense? Otherwise, at least put a question mark. You are going in the dangerous, easy to make a mistake there. Make sense? So at least be careful. If you can find a nodule, which is around 5 millimeters, and you find it in this peripheral lung, then I'll buy it. Make sense? Then I need to say you are right. If you show me something small, let me see. There. Oh, these are not DICOM. So, but that's probably around 2 millimeters. And it's in that region and that opaque. I put a big question mark. Makes sense? That is very likely a vessel. It's not a nodule. Make sense? I'm not going to go through that. We've been through that before. And I forgot, I'm going to publish, I'm going to upload to the blog. Again, that experiment with the Play-Doh and a little bit more of an explanation. The same one that I showed the other day, I'm going to put in there so you can revisit and talk about that. Now, what I'm concerned about, or the things that I think we need to go deeper in, is the two important findings that I think are the most obvious. There is an increased opacity. This part looks more opaque compared to that part. I think we can localize that to the right. And then there seems to be a separation of the lung from the wall here. So tell me more about that. What is that? How can you explain that increased opacity? And probably Paul's point, the contour of the heart. I think that is going to come together. But so if there is more opacity, there is going to be somehow more tissue somewhere. Where is it?
I think in this case, it's probably it looks like an alveolar pattern to me, because I'm not seeing any of the vessels or anything running through.
Okay, what you are saying makes sense. So increased opacity, and you are saying you are not seeing vessels.
Yeah, not in the area in the
Okay, and because you don't see vessels, then you are basically what you are thinking is this fluid. The fluid is in contact with the vessels, like the grapes surrounded by water. Therefore, I don't see them. Okay, yeah. I'm gonna challenge you.
Okay.
If that is the case, first, I think I can see vessels.
Yeah, okay.
But probably more important, that is against your own principle or your own description of you being able to see the contour of the heart. If there is so much opacity in that lung,
yeah,
the opacity in the lung should go against the heart. Makes sense? If you go in the book, then there's going to say that an example of an aspiration pneumonia, So now there is increased opacity within that lobe. And one of the features, if it gets enough, makes sense, if there is enough fluid in that lung, if that lung is in contact with the heart, you should erase the contour of the heart.
Yeah.
Makes sense? It's the same principle. And now I have a second challenge for you. And it's the challenge of how can you explain this if you are putting that in the lung? Make sense? That
Yeah.
So again,
Well,
if you go to the book, in the book it's gonna say if you're gonna one of the features of the alveolar pattern, which is gonna be a wet lung. Makes sense? So I like your point. Basically, what we are saying, instead of saying this is an alveolar pattern, what we are saying is, I think that the increased opacity is within the lung. You can even ignore how to call the pattern. You are saying the lung is the one that has the increased opacity.
Yeah.
If that is the case, usually, unless you are in the border of two lung lobes, and we call that a lobar sign, usually the disease within the lung has ill-defined contours. Makes sense? So it would be extremely unusual for a disease within the lung to have this contour. Makes sense? It would be extremely unusual for this part of the lung to be affected and then to have a very sharp delineation to the unaffected lung.
Can I hit you back with a thought?
Absolutely.
There,
yeah.
So I guess my sort of counter to that would be if you had some sort of disease I'll draw here that was then somehow causing compression of or atelectasis, is that theoretic? Like, is that possible? And then that would also explain why you've got that perihilar shift as well that Anna was talking about. Is that at all a feasible explanation, or not really?
No, I like that. So then this increased opacity here, where is it located?
Well, that would be outside of the lung tissue.
I like that.
Yeah.
That's perfect. Now you're using that feature. So this separation of the lung from the wall is actually a feature of pleural disease.
Yeah. Okay, cool.
Makes sense? So that's a very, and I think you can use it always. That clear separation of the wall, is displaced from the wall, and that line is sharp. It's telling you that there is something outside. Very, very likely. Okay, so now, good. So now the increased opacity, now we are trying to figure out where is that increased opacity. At least we should consider, at least that part here is pleural and is separating the lung. Okay. Do you think everything is pleural? Do you think basically we are dealing with a pleural effusion?
No.
Why not?
Well, I think just as I said there, unless we've got a pleural effusion and then we've got a secondary sort of lung pathology as a result, I'm going to stand by my previous comment that I'll do it on this lateral, and maybe the lateral is a poor choice for determining it, but I really just can't see vessels or anything like that in that area that I just highlighted. And when I zoom in on my big screen. And so that's making me more think of, at least there's some sort of, I mean, thinking about it now, I guess it could be, if you had really bad atelectasis, that could cause that as well. So if there was some sort of pathology outside of the lung that was then compressing the lung, I would buy that explanation. But I can't, so that's sort of where I'm at in my mind.
I want to bring these two findings that you are talking about, which is you brought the separation, and we agree that it's pleural, and then you brought the inability to see the contour of the heart. And what I'm going to say that they go together. So there is no conflict there. Makes sense? So if you have something in the pleural space, that something in the pleural space is outside the lung. So in the same way that it could go against separate the lung, it could go against the heart, and then it can blur that contour. But then, if that is the case, which, perfect, why is that we can see the caudal contour? What is not fitting is, if this is pleural effusion, like a pocket of pleural effusion, makes sense? And I'm saying pocket because it's not evenly distributed. Makes sense? It's just kind of just cranially. If we have that as fluid, and we use that fluid to justify our inability to see the contour of the heart, then what it doesn't fit in this picture is that we should not, by the same argument, we should not be able to see the color contour of the heart.
Right.
Makes sense? So what is in contradiction here is the idea of, not the idea of a pleural disease, but the idea of fluid in the pleural space that is somehow behaving like fluid here, but not behaving like fluid here. Hopefully you have fun with this and not get like, we are talking about something like crazy. Hopefully the arguments are clear enough to go and crush to the contradictions. Make sense? So I'm pushing you to contradictions.
Yeah.
And then see, there's going to be, at the end of the discussion, there's going to be something that explains everything actually. Makes sense? But it's cool to hit the wall. Makes sense to say, if I have this hypothesis and if I run with the hypothesis, then I find this obstacle. Makes sense? Then it doesn't make any sense. Then we need to find another one. So that is kind of, we are doing what I think is a lot of fun doing, which is hypothesis testing. Makes sense? We bring a hypothesis and we run with it as far as we can. And then there's a point where we find a block, and then we need to start again. So we are still with the idea of, and I can even bring more stuff. So we have the separation of the lung from the wall. We have, I think there is a mild mediastinal shift to the left. And I also think that the diaphragm looks abnormal. It's very subtle, but it's flat. How are you gonna, and then we can still see the contours of the heart. I'll probably come back, and can we erase that? Whoever was you, Paul? Okay, I think, so we clear up. I think we can see the contour of the heart both ways. I think the cranial contour of the heart is here. I know that it's not as clear, but do you see it now?
Yeah, I saw that before, but I just felt like I was sort of creating it based on where the contour should go. So now that you've pointed it out, I feel better about it. I wasn't happy to call it on my own.
But actually, I'm not solving any contradiction. I'm even bringing more contradictions. Makes sense? Because anytime we think about pleural disease to start explaining this finding, then we hit the wall when we see that. Makes sense? Because that is completely unexpected in pleural disease. If there is enough pleural effusion to create this overall increase in opacity, then we would expect that contour of the heart to be gone because of the grape surrounded by fluid. Same exact principle. Any other hypotheses? Probably a way to think about this is anytime you hit this wall and then you don't know where to go, you should go like, is it in the wall? You can go, there are not too many compartments. Is it in the wall? Is it in the pleural space? Is it in the lung? Or is it in the mediastinum? That's the first assessment. And the next one is, which type of tissue are we talking about? Is it gas? Is it fat pieces of tissue? Is it bone? Is it metal? Make sense? So you can really go out and now start thinking about, all the possibilities are out there. So we got stuck in terms of the location. I argue against your comment that this is lung, because even though I think that there is increased opacity, I think we can still see the lung vessels, and we don't see air bronchogram. So that is the argument to go against all of that opacity being within the lung. And then we are stuck with the idea of pleural disease, because actually one of the features here is kind of telling us that is behaving like an extrapleural sign, it's coming from the outside. But at the same time, if that is fluid, then we have a problem with being able to see the heart. And then we are left with mediastinum, which is hard to buy because that is clearly on the right hemithorax. So I think we are there. We are kind of stuck there.
So likely extrapleural disease because of the fact that it's similar soft tissue opacity to the wall and it's a convex pattern kind of contour coming off the wall. Is that what you're saying?
Yeah, so I think I really buy that, and that is an important finding. And is acting like an extrapleural sign, like a pleural disease, displacing the lung, separation of the lung from the wall. That I buy. So that is helping me to think that that is in the pleural space. So one way to think about it is that it's kind of a pyothorax and it's kind of pocketing, and that's why, you know, it's up here but not down here. The problem that I have is that there seems to be a lot of increased opacity in that hemithorax. So I expect to be more fluid in the pleural space, also to explain this increased opacity. And in that case, I kind of have the expectation that I should have silhouetting of the cardiac silhouette. So this is where we are stuck. So if you don't want to bring any other hypotheses, I'm happy to bring the solution, and you're going to have fun with the solution. And it's going to come in this shape. Okay. I don't know if this is probably the best. Let me go there. Okay. So I go cranially all the way, and then we come caudally. I'll run it slowly. I will share the link, so then you can take a look at this case carefully. I'm gonna run slowly, and then I'm also interested in you commenting on the CT. Okay, is it helpful?
It'd be really interesting to see the contrast CT of that. Because
This is contrast.
It is contrast.
Yeah.
Right.
I'm pretty sure. Oh no, this one is both. Yeah, there we go.
Mm.
You want me to reconstruct? Oh, I have these tools in here. Okay, let me. Oh.
It appears to be a soft tissue mass as I see it.
Oh, I never had this issue. All the Zoom tools are on top of my my other tools. I can't. Let me bring it out and see if I can. Oh, this is so annoying. Can I reconstruct here? Okay. Ah. Okay, this here. It's gonna be a reconstruct 2D, 3D. Okay. Okay. Solved it. Okay, there we go. This is probably not the best. We go here. 2D, 3D, multiplanar. Okay. Okay. So this is more like the radiographic projection here. And now I want to play with the ideas. The reason why I brought this case is as a continuation of the idea of the grapes. So now we go very simple, not so much in location. The exercise that I want you to play is the exercise about opacities. Okay? So do you remember the opacities? When I show you the grapes, there were two opacities. There was the opacity of the grape and air. And then the opacity of the fluid was the same opacity as the grape. Make sense? So the rule that we use, that what we call it border effacement, that make the grapes disappear, was the situation where we have two structures with the same opacity, that's a key, in contact, which is also key. Make sense? Those two conditions are very important. If we have two structures with the same opacity, like two grapes, but they are not in contact, they superimpose, but we can still see them. If we have two structures with different opacity, like gas and grapes, we can still see contact. So now the exercise in this case, okay, I'm gonna point out, and then you tell me the opacity. What is this opacity? Here.
That's bone.
Bone. What is this opacity?
That's soft tissue and blood.
Perfect. What is this opacity?
Probably fat.
Very good. What is this opacity?
Yes.
Okay. Now we come back to our case. And now we see the increased opacity on the right hemithorax. What is that?
Fat.
Yes. And that now solves all the problems. Make sense? Now having fat there, if we come back to the radiograph, I'm happy to do that. So now, okay, it's in the pleural space, and that's why it explains this. Now there is a little bit of fat there in between the wall and the lung, and also explains why we can still see the contour of the diaphragm and we can still see the contour of the heart, because one is fat, the other is soft tissue. Make sense? So we were hitting that wall, and now we solve the problem. So the location is in the pleural space, everything fits, and the consistency, the attenuation of that tissue is not fluid, but fat, which is more opaque compared to gas. Therefore, it looks like an increased opacity, which makes complete sense, like here, but it's not behaving like fluid in terms that it's not silhouetting. Make sense? So now we just untangle the whole thing, and now by saying that there is a lot of fat in that pleural space, then we can explain. Now the next question is, how can we end up with fat in that hemithorax behaving like this and not so much on the other hemithorax? Make sense? Now we understood the images, and now we need to make a story how we can end up with that. Do you have an idea?
Is it like a lipoma or a liposarcoma, a neoplastic or hyperplastic process?
That is actually a good idea. It's uncommon, but it's a possibility. They really behave more like a mass. So I would not expect, like in this case, see, this is kind of going and extending that way, and then here is not really acting like a mass. There is a shift. Somehow it's acting like a mass, but not that much. But it's a good idea. Any other idea?
Maybe it's a pericardioperitoneal hernia just full of fat.
Very good. So that is another option. What I dislike from that comment, or what I would argue, is that I don't think it's a peritoneal pericardial, because in that situation, then the contour of the pericardium is going to be very big, makes sense? And then you will see the heart sitting within that pericardium. But the fat that we see should be contained within the pericardium. In other words, it's not going to be here, but it's just going to sit just around the heart. And I have a beautiful example I'll bring in next time. But it's a good idea.
Could it be diaphragmatic hernia, like Bron said, going into the thorax outside of
Very
the?
good. So now CT is going to give us a beautiful opportunity to go and look carefully. Okay, and I'm gonna use this plane, and I'm gonna go from dorsally. Makes sense. I'm gonna move these, and I go dorsally, and then I'm gonna go slowly ventrally, and then you tell me if you see any interruption in the continuity of the diaphragm. Make sense? If you can see something that is telling you that actually the content from the abdomen is going into the pleural space. I want you to look at here, basically. Yes, no?
Yeah, there's looks like there's a break in the
Yeah.
diaphragm against the wall.
There, very small. But that's the defect in the mediastinum. Here. You can see the vessels going across. So obviously, I don't want you to, you can't see this in the radiograph. The reason why, and I hope it wasn't a very annoying case. I love this case. And I didn't make the diagnosis to start with. I was extremely confused. But I wanted you to be confused because now if you review the radiographs, I think there is a nice take-home message that is all around this idea of that we have different opacities, and when we see things or when we don't see things, you know, how we can use that information. So when we come back to this radiograph, basically we have the information about the extrapleural, we have the information about the shifting, and then we have the information that there is no silhouetting. Makes sense? It's not border effacement. So now with the retroscope, everything makes sense. And somehow we should have managed to go to the idea of there is just fat in that pleural space. Make sense? Everything is there. Then if we could, I guess the reason why we don't think about it that much, because it's quite unusual. Makes sense? So then we are trapped with the idea of fluid, we can get out of that. We are trapped with the idea of lung. But if you go further, there were problems with those hypotheses. Make sense? And then coming back, everything makes sense. Everything is there, and there is no conflict. Since then, and I honestly, I tell you, I was very lost in this case, like anything, until you see an example. Since diagnosing this, I go like 3 more that they look very, very much similar. So it's not that unusual to have just fat herniating. It's not that unusual. And then it looks like this. And now, next time you see something like this, now you're gonna go through the same mental process, and then it's gonna be a lot easier to call it. This is different from pleural effusion. Makes sense? This is a feature of extrapleural. I come back to your point. You said somehow there is a contradiction here. You said the opacity of this looks like the wall, and I agree with you. And the way that I would argue that this is still fat is because it is thicker. Do you remember that we play with the thickness? So the opacity is not only related to the tissue, the composition of the tissue, but it's also related to the thickness. And that is the reason why it looks more wider compared to this. Make sense? It's just, there is more, it's thicker, it goes along the wall. Okay, was it good? When we talked about the grapes last time, and there was a question about the silhouetting and the border effacement, I immediately thought about this case, because this really brings that, this forces you to use those concepts and to put them in practice. Make sense? What are the things that you see, what are the things that you don't see, and you get to contradictions in terms of if you want fluid, like in this case, if you want fluid either in the lung or in the pleural space, there is something big that is not fitting, which is the lack of border effacement. And that should ring a bell. Makes sense? It should make you think about an option. And then the option is fat, which is the other component. Makes sense? So if you're gonna go to the abdomen, we are gonna talk. So when we are in the thorax, is all about silhouetting in between soft tissue structures, lung vessels, heart, diaphragm. If we see them, if we don't see them. If we go into the abdomen, it's going to be all about soft tissue and fat. Make sense? It's the peritoneal fat. That's going to be our two main players. There is gas in the GI tract, but that is if we are lucky. Sometimes there is not. And then we are left with these two components, fat and soft tissue. Thorax is more soft tissue and gas. Make sense? This is the game that we play. Any question, any disagreement, anything that you want to challenge? I anticipate that probably I've lost some of you in this journey. That's why the images are there. And that's why we have the blog now. So I will be more than happy for you to, if I've lost you in this journey, go back to the images and see if you can put a question together and put it on the blog. And I'm more than happy to answer, and then it may not take, I may help you to get out of that. Yeah, this is one of the central points in imaging is the opacities and how they work together. Makes sense? What happened with the interaction of opacities. And this is a beautiful example just to show them.
I have a question, Mariano, about the diaphragm that Lucy pointed out, how it looks quite flat there. Is that because there's loss of potential pressure in the abdomen herniating into the thorax?
You know that I don't know. Let me bring the CT. And one hypothesis that I had was that actually that's not the diaphragm, but is the liver actually.
Because yeah, to me it almost looked like those feline asthma cats where they've got that really sort of hyperinflated lung look.
Mm-hmm. Yeah.
But see that the diaphragm is flat there. So I don't know. Probably there is some pressure on the other side. Make sense? This is acting like a mass. So in the same way, see the shifting becomes more clear in the CT. There's a shifting of the heart. Actually, that is one of the features, indirect features of hernias. Makes sense? So sometimes you don't see the rupture of the interruption in the continuity of the diaphragm. So that's the evidence of our primary, direct evidence. The indirect evidence is shifting of cranial displacement of abdominal structures or shifting mediastinal shifts. Make sense? Because there's something in that thorax that doesn't belong. So I think this change in the appearance of the diaphragm or liver, I'm not sure, I think this is probably still diaphragm, is because there is now a new tissue there that is occupying a space and is displacing the heart to the left, and then the corvina cava to the left and the diaphragm cowling. I think that's the reason why it looks flat.
I wonder if there's also overcompensation in the thorax because there is less right lung space as well. Anyway.
Like overall increase in the volume.
Yeah, trying to overcompensate and get enough perfusion that way. So kind of like what Lucy was saying with the asthma cats, hyperinflated.
Ah, yes, yeah, absolutely. Yeah, so basically, the mechanism is different. In the asthma cat, what is larger is the lung, and then when the thoracic cavity gets larger, the diaphragm flattens. And in this case, it's because there is a new component in that thorax. But yes, I agree. So basically, we should put this finding, which is the flattening of the diaphragm, together with this finding, that is displacement of the heart. Makes sense? So now if we go back to the original images, the thing is that features are very, very mild. You know, you really need to be, have a lot of, let's say, self-determination. You know, you need to be hard, you need to be tough to really go after those findings. They are mild to say there is a mass effect. Makes sense? There is a mass effect. Now there is increased opacity in that chemithorax, and also things are moving away from that chemithorax, moving away caudally, moving away to the left. Subtle, but it's there.
Just as an aside, Mariana, did it have the ultrasound put on it at all, this cat, or did it just go straight to CT?
I think we diagnosed it with the ultrasound, but I think then the reason the the idea of the CT was to know exactly where was the rent for the surgeons to plan the surgery. And basically, I remember we saw like, we knew about the tissue. I was very confused about this. And then we put the probe, and then everything came in place. But then there was a question, is it a lipoma? Is it a diaphragmatic rupture? I don't see the interruption in the continuity of the diaphragm. So then as a reasonable next step is, depending on your surgeons may say, look, I'm happy with this. I can take a look at the whole diaphragm. And then if we go that way, I remember there was a question, we had these two options. Is it a purely intra-abdominal disease, a fat opaque mass, or is it a herniation? And then I think that was the justification for the CT.
Was there a consideration of not treating it? Do you know?
Good point. I don't remember, but it's a good point. Yeah. I don't remember exactly, what was the conversation at that time. But certainly that's a very good point. Okay. Did you enjoy that one?
Very interesting.
I love talking about this case. I love talking about this case because I was the first one struggling a lot. I remember the day they brought this case, they wanted a CT. And anytime someone wants a CT, I said, do you have radiographs? And said, yes. And said, here they are. And I remember staring at these radiographs, and I remember staring at these, and I thought it was a biothorax, but then I couldn't explain that, so I was lost. And then we said, well, if that's a biothorax, let's put a probe, and then I kind of untangled the case that way. But I remember struggling. But now I love the case because you struggle, but then when you get to the end, everything falls in place. Everything makes sense. So, and that makes it a good lesson. Okay, yes.
It was a brilliant teaching case, I thought.
Really, yeah, I love it. And I love that I have the CT. So then I love showing that CT, and the opacities here become even more clear. Makes sense? So in a radiograph, because there is this problem of the thickness, then the attenuations or the opacities sometimes are confusing, because if you have a lot of fat, looks like soft tissue, and that's confusing. CT is just brilliant. Like here, that's liver, that's fat. It's very different. Makes sense? So this is clearly fat, and it's not in. And by the way, in CT, those same principles that we were talking about, the silhouetting, makes sense. The grapes surrounded by fluid. Actually, I have a CT of that, and I'm happy to show you next time. Works almost the same. Makes sense? So because the principles are still X-rays, the principles are still attenuation, stopping X-rays. So if you have grapes and you put water around them, the same thing works with CT. Makes sense? You're going to have body effacement. Actually, the vocabulary that we use is very similar. So in this case, I also love that I have the CT. Makes sense? So now I can clearly show the difference in between soft tissue, fat, gas, bone. These are the game. These are the players of our game. And how they interact when they are in contact, when they are not in contact, when they superimpose or when they're not superimposed, are key elements of our game. If you understand those concepts, then you can, untangle the cases in a nice way, in a logical way.
Yeah, I thought the way you went back to basics, just looking at tissue densities and use that to solve the problem was really important.
That is the whole point of this case, and it came because of the grapes. Make sense?
Yes.
It's reinforcing, it's using that information in a case. It's putting that principle in action. Okay, good. I got a lot of fun. I love doing this. So I hope you had fun as well. We keep on accumulating cases. It doesn't matter. They are there. So if you have the time and the willingness and the energy, you can take a look. And now we have a blog. so you can make comments. Make sense? So probably next time we can already catch up from a question. Make sense? Rather than to start from zero in the case. We'll see.
Excellent. Is there any other questions anybody wants to ask before we wrap up for the day? Super. All right. Thanks so much, Mariano, again. That was an awesome case. Really cool. Next rounds will be me on Friday at 1 p.m. and we'll be discussing some blood test results of patients with diabetes. So we'll go through a few glucose curves of cats and dogs taken in different situations and things, and also some DKA blood tests. So anybody wanting to come, I'll send out the invitation in the next 24 hours or so. And a copy of Mariano's rounds will be up on the app within the next 24 hours as well. Thanks again, and we will speak to you all soon.
Thank you.
Thanks, Mariano. That was great. Thanks, mate.
Good.
Thank you, Mariano. That was wonderful.